The objectives of this session is mainly to identify the imaging findings of the most common injuries affecting the athlete with lower leg pain. I will also try to show the value of different diagnostic imaging techniques in the athletes presenting lower leg pain. After this lecture, we should be able to choose the most appropriate imaging technique when we have a patient with this type of pain. I will include a comprehensive review of the anatomy, physiopathology, clinical findings, differential diagnosis, and imaging features of the lesions affecting the athlete with lower leg pain. So, which tissues do we have in the lower leg? So we have bone, we have muscle, we have blood vessels, and we have also nerves. So the following topics will be discussed. Any of these tissues can be damaged and can give pain. So I will discuss the bone stress injury spectrum, muscle strain. Also, I will show some injuries of the muscle that they are not muscle strain. I will talk also about few pathologies regarding vascular disease and the peripheral nerve. So let's kick off with bone stress injury spectrum. The bone tissue dynamically remodels in response to mechanical stress. In case of submaximal strong and repetitive bone overload, with adequate recuperation, the tissue adapts to the load and can experience further loading without damage. In case of a strong chronic submaximal repetitive forces in the bone without sufficient recovery, the osteoclastic activity can surpass the osteoblastic activity, thereby creating microfracture and weakening the bone. If the mechanical stress doesn't stop, the microfracture may propagate and end up in microfracture. The presence of microfracture is considered to be a stress reaction of the bone. In case of macrofracture happen, in case of a macroscopic fracture line is seen on imaging, it's considered to be a stress fracture. I include these two types of injuries, the bone stress fracture and bone stress reaction, in the more generic concept of bone stress injury. I call it a spectrum because it's a continuum from bone stress reaction to stress fracture. All the patients that we see here in Aspetar are normally athletes, and they have apparently normal bone. So we consider this type of fracture a fracture of fatigue. I will also show that there is a concept or a subtype of fracture called insufficiency fracture that is the type of fracture of a stress fracture that happen when the bone is pathological, is osteoporotic, normally in all people, in all patients, that with normal forces and not increased forces, they can create a fracture. However, this concept of normal bone is sometimes not that clear. Also, in our patients, in athletes, healthy athletes, there are some factors that can make the bone more prone or less prone for stress fractures and stress reactions. Those factors are the genetic healing capacity of the patient, some hormonal disorders that sometimes they are subclinical, and also the nutritional status like vitamin D deficiency or vitamin C deficiency can make the bone more prone and a little bit weaker and weaker with bone stress injuries more likely to happen. Regarding the biomechanics, we also have to understand that bone stress injuries happen in specific areas of the bone. It doesn't appear anywhere. Normally, it affects the tension side, the maximum tension side of the loads, and the maximal compression side of the bone. So the bone stress injuries that arise from the tension side of the bone, as we can see here, this is a picture of like a diagram of tibia with a posterior view, and we can see this red color, that is the posterior medial tibial cortex, that is the compression side, and in the front we have the anterior tibial cortex, that is the tension side. So bone stress injuries that arise from the tension side of the bone are considered as high risk. They don't have a favorable natural history, they present longer return to play, and they can also lead to a complete fracture. High-risk fractures normally require more strict management with ceasing of the overload movement, avoiding of the weight bearing, and in some cases, even surgery. Bone stress injuries that affect the compression side of the bone are considered as low risk and respond well to activity modification. They have a quicker return to play compared to the high-risk ones. How we can see fractures in imaging. So here we have some examples with the different techniques that we normally use. So the first case is an X-rays. In the X-rays, so we can see here, there is a incomplete fracture. It's a radiolucent line. The signs in X-rays correspond to the incomplete fracture. Normally, they are perpendicular to the direction of the load. In this CT scan, this is a coronal reconstruction, and we can see a fracture here. And we can also see some periosteal reaction. This hyperdensity adjacent to the fracture line, this is a periosteal reaction. This is also a radiological sign that can be seen sometimes in X-ray. In MRI, we can see here, this is a T2 coronal view. In this T2 coronal view, we can see some bone edema that correspond to microfracture, or to a stress reaction. Bone stress injury spectrum. Here, there is a classification that I personally use. There are many classifications of bone stress injuries. I use this one, why? Because it's easy, is also quite spread use worldwide. I think it's one of the most common classification. This classification was described by Fredrickson and modified by Kajowski. Here we can see the grade 1 is just a periosteal edema. The grade 2 is periosteal edema with subcortical bone edema, only visible in T2. The grade 3 is bone marrow edema, visible in T1 and T2. Grade 4A is when we find foci of alteration of signal within the cortex. And grade 4B is when we see this fracture line. In this bone stress injury spectrum, the grade 4B is considered as a stress fracture itself. The other grades are bone stress reaction. Which imaging technique we should choose? So let's see which type of grade the different imaging techniques can detect. The X-ray, as we saw before, there is just can detect the incomplete fracture, the stress fracture, has a very low sensitivity for the bone stress injuries because only the latest stage injuries can be detected. CT scan is like a 3D X-ray, so can be a little bit better regarding and can detect also the grade 4A. MRI, as this classification was described for MRI, so can describe all the grades. And bone scintigraphy also is able to detect metabolic activity, when there is periosteal edema, bone marrow edema, so can see or can be as sensitive as MRI. However, I will show you the difference between bone scintigraphy and MRI. On the right, we see a bone scintigraphy image, and on the left, an MRI. So regarding the voxel size or the pixel size, you see in bone scintigraphy is less defined. You are not so specific. You see like a uptake in the bone scan, but sometimes it's very difficult to know if it's an inflammation or is bone tumor or there is a fracture, let's say. However, in MRI, we have much better resolution in detail and we can assess much better. Plus, the MRI doesn't use radiation and you don't need any injection. The American College of Radiology created this criteria of appropriateness. It means like in case of suspected stress fracture with negative, here up. What's the first imaging study suspected when there is a stress fracture? The first imaging study that they recommend is radiography. In the case of suspicion of a stress fracture with negative radiographs and immediate need to know, which is normally our case, our patients, they need the diagnosis. They cannot wait 2 weeks. So the diagnostic imaging technique is MRI. Better than scintigraphy and better than CT scan. I just will mention a little bit about this new technology that this is called the dual energy CT. It's a subtype of CT scan that is able to detect the bone marrow edema. So potentially in some certain settings, in some departments, in some hospitals, may have a role, okay, in the future. They could detect grade 2 and grade 3 injuries. Regarding return to play, in this article published by Kajowski, he found that he found a correlation between grade 1 and grade 4B. Cases with grade 4B has 10 weeks, more or less, return to play. Grade 1, just 2 weeks. The other 2, 3, 4A grades, they have like a 5 weeks of return to play. This type of classification will help in the future to do better studies that probably will be more accurate regarding even describing the tension side, the compression side, and be a little bit more descriptive. But just to let you know that this grading can help to assess a potential return to play. Which is the imaging to evaluate the return to play? Normally, here we do it clinically, and I think personally, I believe that is the best way. Assess clinically the healing of the fracture, because normally in MRI it takes a lot of time and sometimes it never became normal again. However, in this appropriateness criteria rating, the follow-up for return to play, as we can see here, they recommend MRI. I will show you now different cases with different pathologies, so we can a little bit understand how radiologists, how we identify this type of injuries. This is an 18-year-old male with acute pain while military training. All of us, we know that military training is a red flag regarding stress fractures and stress reactions. On the left, we see the X-ray. The X-ray is normal. And we have an MRI. In the MRI, this is a T2 FATSAT from top to bottom. And we can see here the tibia, fibula, muscles anterior, muscles in the posterior side. And we see here this hyperintense line. This is a periosteal edema. This is a grade 1 bone stress injury and is located in the anterior tibial cortex. So let's remember that this is like a high risk area. Let's go with the second case. This is a 17-year-old male referee. We always see this sequence. This is the most useful sequence. If I have to choose only one sequence that I can see in MRI to identify pathology in the cuff, I will go for the axial T2 fat sac. So here we see a normal bone marrow edema in the tibia, which is dark because it's fat, and with fat suppression is became dark. Over here we see the tibia with periosteal edema and some bone marrow edema. In T1, we see here we have the marker. And we can see an area of hypointensity on T1 in the bone marrow edema. So we have here the periosteal edema affecting the posterior medial cortex with decreased signal intensity on T1, hyperintensity on T2. This is a grade 3 stress injury affecting the posterior medial tibial cortex, so an area of low risk. Next case, this is a 16-year-old male football player with acute calf pain while sprinting. In this case, we see again the periosteal edema in the posterior cortex, bone marrow edema, dark signal on T1, and if you see here, there is a signal, intrasignal, increased signal intensity inside the cortex. So this is a grade 4A. Just to remember, and a small detail that is important, sometimes there are pulsatility artifacts. You know here, this here following the blood vessels, there are like some dots here that sometimes if we are not if we are reporting quick, we can commit mistakes and think that this signal intensity here is actually a lesion. However, it's just an artifact. And this is another case. This is a coronal view, coronal sequence. We can see here on the right side, periosteal edema. We can see like a small fracture line, bone edema. In the axial view, we can see here in tibia a thickening of the anterior cortex, increased signal intensity in the cortex, increased signal within the cortex. That in T1, we can see also one fracture line. There is a linear intracortical signal change, grade 4B. As we can see here in the X-ray that I didn't show you before, there is a fracture line in the anterior tibial cortex. So this is a, let's say, high risk. This case is a bonus case just to remember that bone stress injuries doesn't affect only to tibia, they can affect also the fibula, okay? Same signs, you know, this is a 22-year-old male handball player, pain in distal fibula that increased with load. This is the last case of this part of the bone stress injuries, and this is a 31-year-old male football player with pain in the anterior tibia that increases with load, and you can see here the typical incomplete fracture of the anterior cortex, high risk. This is 6 months after. 6 months after, this patient apparently didn't stop playing. He didn't recover well eventually. As you can see here, this is the original incomplete fracture. Now there is a fracture a complete fracture of all the tibia. Okay, let's continue with the second most common injury of the leg, which is the muscle strain. Again, the muscle has, as any material, elastic and plastic zone, and has a failure zone depending on the load, on the stress that this muscle is under. How we see the muscle strain in imaging? So mainly with muscle edema. A grade 1 injury normally is muscle edema. As you can see here in this coronal view, this is MRI view, we see increased signal intensity. They describe as feathery because looks like a feather, okay? And this is the typical grade 1 injury. In ultrasound, it corresponds with this area that is hyperechoic. Normally, people may think the people that do ultrasound, okay, why is not hypoechoic? Because normally water is hypoechoic. Is hyperechoic because this is more bleeding, let's say, to make things easier. Okay, that's why we see these grade 1 strains as hyperechoic instead of hypoechoic. The grade 2 injuries consist on disruption of the muscle fibers. As we can see here, there is increased signal intensity with disruption of the fibers, and here a very large disruption of the fibers in ultrasound. MRI is in general more sensitive and is considered the gold standard. It's true that could be debatable. Some people with experience on ultrasound can have a very good sensitivity, but the science to date with the technology we have showed that MRI is more sensitive. And in my experience, I agree with this statement. I feel ultrasound is still, in some cases, is useful. In some cases, we see. In some other cases, we don't see. When we see a muscle injury, we have to describe. The way to describe this type of injury is first, location, where inside the muscle is the injury, myotendinous junction, myofascial junction, intramuscular, or intratendinous extension. We will also describe the severity with the grade 1, 2, 3 system, as we showed before. There is this relatively new classification. It's not that new anymore, but it's getting very popular and normally analyze all of these fractures in one classification of grading. Okay, in the cuff, the muscles that normally strain are the muscles of the posterior cuff. The muscles of the anterior cuff, normally they are never got injured. So we have the gastrocnemius, medial and lateral, and soleus. Time before, I remember when we saw one MRI with a lesion of the muscle of the cuff, we just describe, okay, this lesion is in soleus, okay, this lesion is in gastrocnemius. However, we now don't do that anymore. We are more precise. We know the anatomy better of these muscles, and we know they have some implications or potential implication in the return to play. So I will describe and I will show you the complex anatomy and how this complex anatomy has this reflection on the return to play. So this is a very basic diagram that here we have, this is the soleus. There are three intramuscular tendons. There are two cranial, one medial and one lateral, and one a little bit more distal. The two proximal are called the medial and lateral aponeurosis, and the distal one is called the central tendon. All of them go from anterior to posterior and from superior to distal, from top to bottom. There are also two fascias, the anterior fascia and the posterior fascia. And here in this diagram, in this transverse diagram, we can more or less identify the tendons and their position within the muscle because they change. In the anatomy that we see in MRI, we normally use in axial, so that's why this is the most important part of this diagram. According to the Football Club Barcelona Muscle Guide 2018, there are a correlation between where the injury is inside the muscle and if there is large or little connective tissue involvement and the estimated return to play for soleus and for gastrocnemius. So a little bit like generalizing, and it's true that every player is different, every sport is different, but these scientific papers more or less orientate that a lesion affecting the medial aponeurosis could take 5 weeks of return to play, lateral aponeurosis 4, central tendon 6, posterior fascia and anterior fascia 2 to 3 weeks. So let's continue seeing like different cases of muscle strain of the calf, and so you can understand how radiologists we identify the injuries and describe the location. So this case is a male 31-year-old football player with acute pain during training. So we clearly see one signal intensity. Okay, here, this is the soleus muscle. The soleus is coming here. This is the central tendon. This is the lateral aponeurosis, and the medial aponeurosis will be in this way. So this is a soleus injury with a muscle strain that affects the medial intramuscular aponeurosis. Okay, so we can more or less guess that there is a return to play of around 5 weeks. Another case, 44-year-old male with acute pain while running. Again, we see some muscle edema in the calf. This is the gastrocnemius, lateral gastrocnemius, soleus muscle, all up, all this area. So this is the central tendon. Okay. No, sorry, this is the central tendon, and this is the medial proximal aponeurosis. The lateral aponeurosis will be this way. Here in this picture, we can see the central tendon involvement, large connective tissue involvement, longer return to play, 6 weeks. Next case is a 24-year-old male football player with tightness and electricity feeling. Again, we see a muscle edema within soleus, okay? This is soleus, and this is central tendon, medial aponeurosis, lateral aponeurosis. Muscle injury affecting the lateral intramuscular aponeurosis. Let's continue now with the gastrocnemius. The gastrocnemius, this is an research published last year, so it's quite recent. This type of injury, the medial gastrocnemius or the gastrocnemius injuries, are the one that we traditionally think about the tennis leg, okay? And this article describes in a very precise way the anatomy, and also describe, analyze which injuries, which structures are injured and its return to play. So in this detail, this is the coronal view. There is a gastrocnemius muscle, soleus muscle. So this detail goes here. So this is soleus, this is gastrocnemius. In yellow, we have the gastrocnemius aponeurosis, which is important, is the aponeurosis that is in contact with soleus. And here we have the free gastrocnemius aponeurosis. These two structures, the orange and the yellow here, are important because the lesion of any of these structure will let's say, determine a longer or shorter return to play according to this article. Here in this patient, we have perfect aponeurosis, just bone edema here in distal gastrocnemius. Here we can see injury of the free gastrocnemius aponeurosis. And in this transverse view, we see here, I don't know if you can see, this is the gastrocnemius aponeurosis, and there is a tear here. There is a small tear here. Okay? According to this paper, when there is no involvement of the aponeurosis, as we can see, type 1, the return to play is very quick, it's 2 weeks. However, when the injury involves the gastrocnemius aponeurosis, and the free gastrocnemius aponeurosis, will have a return to play up to 7 weeks. I will show you a couple of cases describing this type of injuries. This is a 39-year-old male with acute onset pain while playing football with kids. This type of injuries of the medial gastrocnemius normally affect people starting 40 years, more or less. I consider this injury like a midlife crisis injury. Here we have the one muscle hematoma. There is here the gastrocnemius aponeurosis injury plus free gastrocnemius aponeurosis injury. This lesion will have a very long return to play, approximately 7 weeks. It's a type 4. And another case, different case we see some muscle edema here in gastrocnemius. Remember, this is gastrocnemius muscle. This is medial, this is lateral. So we see some muscle edema. With a little disruption of the gastrocnemius aponeurosis. So we can classify this patient in type 2A. So approximately 3 weeks return to play. I will show you now 3 other cases of the muscle strain differential. Not all muscle edema is a strain. Sometimes is another pathologies. The case 12 is a 18-year-old male football player that was tackled by an opponent. Okay, here we can see the marker, tibia here, and we feel there is some muscle edema, all of this area, also some soft tissue edema adjacent. So normally when there is a kick, there will be edema in all of this area without any. Is not limited the muscle edema, the edema to one muscle. It's an area that can involve muscle and also soft tissues. So be careful with the muscle edema that is not at the real place or the normal place. Normally, as we saw in the previous cases before, the muscle strains, they are located in some specific areas. When we see a more diffuse muscle edema with especially soft tissue adjacent soft tissue edema, think about muscle contusion. This is another case, 20-year-old male left calf pain football player. And more or less, if we could a little bit follow the talk, now we can see that this is the soleus muscle, okay? And this soleus muscle, this is the gastrocnemius, medial and lateral. This is the medial aponeurosis, lateral aponeurosis, central tendon. And we can see some muscle edema, okay, muscle edema. We could say, oh, there is a strain affecting all the myotendinous junctions. However, this is a delay onset muscle soreness. Is diffuse edema in one muscle or one muscle group, normally underlying the surface of the muscle. Is just muscle edema that appears after 48 to 72 hours after exercise. Delayed onset muscle soreness. Think about that. The last cases of the muscle section is this one. Normally this type of patient have a very characteristic complaint that is bulge. This is a patient with bulge since 4 years in the calf. Is a volleyball player, and when we do ultrasound, we can see here, this is the muscle, this is the soft tissues, this is superficial, this is deep. So the fascia of the muscle goes here, and now we see something popping out. Okay, this is a muscle hernia. The muscle hernia is the muscle protruding through a fascial defect, and normally the clinical symptoms are very specific. Okay, ultrasound is very good because you can ask the patient to do construction, because normally those injuries are more evident, accentuated during construction. They call it as a mushroom cap appearance. Mushroom cap appearance. So here, this is not a calf, this is a thigh, but the case is beautiful, and I like to highlight how we see in MRI. Here, the fascia will be here, and this is the muscle cap, the mushroom cap, sorry. This is the vastus lateralis of quadriceps. Just to finish this session, I will discuss some rare cases, normally they are very rare, of vascular disease and the nerve. The first case is the most common, let's say, even though it's rare, we see quite often. It's not that rare. So this is a patient with post-traumatic calf pain since 10 years that became worse in the last days. It's a handball male, and eventually we did MRI. So here in the MRI, here is the marker. So the pain is here, and we see this muscle edema. This muscle edema is located in soleus, could be a muscle strain. Yes, 100%. However, here we notice in the blood vessels something abnormal. Normally, veins are hyper intense on T2, so they are white. However, here we see like a vein that is not that white, it's like dark, it's like a dark dot. In coronal view, we see the vein dilated, and there is some foci, as you can see here, filling the vein. So we thought that maybe it's a clot. It's a clot. Same here. In T1, we can also see this hypointense void inside the vein. So the next step was to do ultrasound, because under suspicion of deep venous thrombosis, the best imaging technique is still ultrasound. What we do here, the images are not very easy to understand, but this is the normal side, and this is like pathological side. Okay, so think that there is like an artery, there is a vein, and we make compression. In this image, there is compression, making compression with the transducer. So in a normal case, like here, when you make compression, the vein and the artery in a lesser degree can collapse. However, if there is a thrombus here in the vein will not collapse because it's filled with a thrombus, as we see in this case. Artery, vein, here the artery will succeed to collapse the artery, but not the vein. In the sagittal view, in longitudinal view, we can see here the vein that is dilated and is filled with a clot. It is rare, but we also have to understand that athletes are exposed to risk factors like frequent travel, repetitive trauma, and hemo concentration from dehydration. Also, a hereditary clotting disorder may also affect. Ultrasound is the best imaging technique for this type of injury. And why we have to diagnose this pathology and treat it quick? Because there is a likelihood of pulmonary embolism, okay, that is bigger as the proximal the thrombus you can find. In iliac veins, it reaches 7%, and in the calf veins is like from 0 to 46. Another case of vascular pathology. This is a volleyball coach, 49-year-old with cramps at night. We do ultrasound, I don't find anything. No DVT, all the muscles are fine. However, if you see the arteries, see some atherosclerotic plaques, some thickening of the wall. Traditionally, we think about the peripheral artery disease only in the very old people that they have this intermittent claudication only after 50 to 100 meters. We call it the window shop disease, okay? So people walk only 100 meters, they wait a little bit until the blood goes to the calf. However, in my experience, I have seen patients not that old with, let's say, a lesser degree of peripheral artery disease that they cannot perform as before regarding running and exercise. Okay, so think about this. Also, we can see in the X-ray the calcification of the artery wall. I like this case also. This is the last case of vascular disease. This is a 30-year-old male international football player with 5 days calf pain. I do the ultrasound. I don't find any muscle strain, no DVT. However, in the artery, I see some kind of membranes inside the artery and say, what's this? I put the Doppler and there is no flow. There is only this flow here that tapers. And in the transverse view, we see the diameter of the artery and only flow inside. This is a case of popliteal artery dissection, which is very rare. Honestly, here in this hospital, I only seen that case, and is associated to high energy trauma, tibial fracture, and also combined cruciate ligament injury, ACL and PCL. Normally, is a very big trauma with knee dislocation that create a big injury in the artery. So the inner layer of the artery wall breaks. So the blood goes inside the artery wall and collapse the light of the blood vessel. It can create a strong compromise of the circulation and also severe ischemia. So be careful with the combined cruciate ligament injury, big knee trauma. Check if there is think about a potential injury of the popliteal artery. This is a very disgraceful case that happened in my country, and while I was reviewing them, when I was doing this talk, I decided to show you. It was a 16-year-old gymnast, a girl, that she had a knee dislocation during training. She went to the hospital. They didn't do things properly, so eventually she lost the leg. Okay, so probably because it's rareness and people are not aware about this type of injury. Just to finish the talk, I will just mention very, very lightly some cases of peripheral nerve entrapment syndromes. Sometimes we see normal MRI and we see also normal ultrasound. There is no pain, so we don't know what to do. Sometimes there are some pains that they are caused by entrapment of small nerve branches. I will show you here two of probably the most frequent. One has pain here in the upper medial and one in the distal lateral. Okay, we should know where these nerves go, so we can also check in ultrasound exactly at the area these nerves normally impinge and potentially think that this is the cause of the pain that the patient has. So just you to have an idea and just to remember that this type of injuries can happen. Inferior genicular nerve, the pain is mainly in the knee, but also in the proximal leg. Normally the nerve goes under the distal MCL, and sometimes in case of negative findings, persistent pain, we could try to block this nerve as a diagnostic test. The superficial peroneal nerve is also a nerve branch that can be entrapped here, especially when it goes between two muscles covered by a deep fascia, and in this point in the distal leg, it goes superficially. And sometimes after some ankle sprains, the nerve can be damaged here and the patient can feel pain in this side. Follow with the ultrasound, see where the nerve is. Here is the nerve, more superficial. The nerve is deep to the fascia here. And sometimes we can just think that maybe this is the cause, but they are very rare cases. Take-home messages. Not all bone stress injuries are the same. There are bone stress reaction, bone stress fracture. There are high-risk areas, low-risk areas. Not all calf strains are the same, depending the soleus, depending the muscle injury is in the gastrocnemius. We should know precisely the anatomy to provide a potential return to play assessment. Not all muscle edema is a strain. Think about muscle contusion and DOMS. In general, MRI is the best for bone injuries and muscle injuries, but normal MRI sometimes doesn't rule out pathology. Think in ultrasound, remember the artery disease, muscle hernia, DVT, nerve entrapment syndromes. Thank you very much.